Hi, my name's Rachael and I'm from Queensland Ambulance Service. I'm an Advanced Care Paramedic 2 up in Queensland. Just here to talk to you today about bag valve mask ventilation. Bag valve mask is an essential part of basic life support and it's a skill that we use quite regularly in the ambulance service. It's also a skill in my experience that I have found people lack in proper technique purely because sometimes the exposure is not great enough and it can be quite a technical skill for some people. To start off with, I'll talk about the bag valve masks we have in QAS. We use the Mayo Healthcare disposable resuscitator and we have three sizes. We have the paediatric, the neonate and the adult. All bag valve masks have the same properties, including the self-squeezable bag. The bag for an adult has a capacity of 1500 mils, but a maximal compressed volume of 1200 mils. It's important to consider respiratory physiology of the tidal volume of an adult, which is on average 5 to 600 mils or 7 to 8 mils per kilo. In considering that, when adequately bag valve mask ventilating a patient, we would be compressing half the bag. For a paediatric mask, it's 500 mil with a compressible volume of 300, and for the neonate, we're looking at 280 mils with a compressible volume of 160 mils. In looking at the bag valve mask, we've also got the reservoir bag, which delivers 100% oxygen. We then have between the squeezable bag and the reservoir bag two one-way valves, an inflow and an outflow. This looks after delivering room air to patients when you don't have oxygen connected to the bag. Here we've got our oxygen hose, which we regularly connect up to 15 litres per minute to allow 100% oxygen. We then have our patient valve, which allows for assisting ventilations in the spontaneously breathing patient. We then have our capnography, which is the gold standard to ensure adequate ventilation. We then have our bacterial viral filter and our air cushion mask. This mask can be altered with a Luer-Lock syringe to add sufficient air to ensure an appropriate seal. Before going into the process of bag valve mask ventilation, it's important to look at preparing the patient for this procedure. Most importantly is to look at the positioning of the patient. We want to ensure a sniffing position when appropriate clinically to allow for a good pharyngeal access. The only time that you would not do this is in a patient with C-spine precautions, in which case you would not provide head tilt. We use the triple airway manoeuvre as the most basic manoeuvre, and this involves 3 steps. First of all, it involves head tilt, moving the head anteriorly and superiorly to try to get the best airway access possible. We then look at jaw thrust, which involves placing your fingers on the mandible of the jaw and pulling anteriorly to prevent the tongue from occluding the airway, as that is the number 1 cause of airway occlusion in unconscious patients. The third step is mouth opening, using your thumbs to pull the chin to visualise the oropharynx. At this point, you want to visualise the oropharynx and check for any secretions, and at this point you would suction, and then you can add some oropharyngeal or nasopharyngeal adjuncts to ensure airway patency. In QAS, we have a number of oropharyngeal airways from 000 for a neonate up to size 4 for a large adult. We size up the oropharyngeal airway from the tip of the mouth to the angle of the jaw. The indication is for any patient with no gag reflex. For insertion, we place in backwards and we rotate and make sure it's pursed at the lips. The nasopharyngeal airway in QAS, we have sizes 6, 7 and 8, which we would size up from the tip of the nose down to the tragus. This is indicated for patients with an adequate gag reflex and contraindicated in patients with a basal skull fracture or mid-zone facial fractures or nasal fractures. We usually use the right nostril as anatomically it's found to be larger. We lubricate it up prior to, and then you want to go perpendicular. If it gets stuck at any point, give it a little twist and it should sit pressed up against the nose. At this point, we're going to go through the one-handed ventilation technique. This is using the CE grip. We place the mask over the face, ensuring that we have adequate air in the bag mask valve, and we're going to do a C grip over the top with our thumb and index finger, and we're going to use our 3 fingers on the jaw. At this point, we're going to ensure that we pull the jaw into the mask, not push the mask onto the face, as this provides a more adequate seal. To check your ventilations, you're looking for equal rise and fall of the chest, feeling for any air leaks, and you can also monitor your patient's saturations and get your partner to auscultate the chest to ensure you're getting good ventilation. A common complication is air passing into the stomach, purely because we are unable to secure it only to the trachea using bag valve mask ventilation. This can cause aspiration, which is a common complication of bag valve mask. Occasionally in some patients, you can find that you have difficulty to ventilate them due to either them being obese, edentulous, having a history of snoring or sleep apnea, maybe their anatomy being different, like kyphoscoliosis, making their positioning not optimal, and also operator difficulties like small hands or difficulty with the strength of maintaining that seal. It's important in any of these situations that you try to troubleshoot this method by ensuring your position, ensuring you have adequate adjuncts, and attempting to optimise that triple airway manoeuvre or double airway manoeuvre in your C-spine patients. If you still have trouble, you can revert to the two-handed method, preferably with a second officer to compress the bag, but if need be, you can compress the bag using your elbow. The optimal position for this is to place your 4 fingers on either hand onto the jaw and pull it up into the mask, and using your thumbs down over the mask. This should provide adequate seal because it allows much more dexterity on your behalf to ensure that that's patent. If you're still having trouble ventilating with all of these troubleshooting options, then an LMA or ETT should be considered. The other thing that's important to note is for edentulous patients, you can try the lower lip placement, where you just place the bag valve mask slightly higher on the face to prevent that from being a problem. Other than that, just remember, for bag valve mask ventilation, it is a simple technique, it is a life-saving technique, but it is a technique that does require skill, and particularly if you see that you're not getting adequate ventilation, rather than just continuing, it's stop, reassess your patient, go back to basics, and start again. Hopefully you found this helpful. Thank you for watching.